Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. All right. Hello and welcome to the May 2026 Pre-Hospital Care Research Forum, Education Research Journal Club. The PCRF promotes research literacy to advance the science of EMS, educational research, and clinical practice. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. Big thank you to Limmer Education for sponsoring these podcasts so we can bring you the best of science in education. I'm Megan Corey, and I am here with Dr. Kim McKenna, and we are coming to you, first of all, live from New Orleans. That's why you see our decorations here on our first slide, and you might hear some clinking in the background. We have some guests that are coming from lunch to join us as well live. So we are in New Orleans, and we are going to be discussing and we're at ACCREDITCON, forgot to say, ACCREDITCON 2026 in New Orleans. We're going to be discussing this article today, and this is published in Curious Online, so you can get a copy of this. It's open access, and this is called Prevalence and Impact of Simulation Substitution on Paramedic Educational Program Success, a National Examination. So you can find, remember, all of our journal clubs, this one included once we're done, and past journal clubs on our YouTube channel. So look us up at PCRF at UCLA, or you can just search PCRF Journal Clubs when you go to YouTube and find both the clinical and education research monthly recordings, and you could subscribe as well. So abstract submissions, actually, David Page is here. I don't know, David, if you would like to say anything about this, but I just want to announce that abstract submissions for the annual PCRF International Scientific Symposium will be on June 30th. So get your data together. There's a lot of stuff going on at PCRF. So for this and other information about upcoming opportunities to participate in research, there's a few deadlines coming up for research summits as well. Make sure you see our website at prehospitalcare.org. So thank you all for joining us today. We're going to begin, and we want to remind you that you can use the chat feature on your screen, and you can type in questions and comments. People out here who are live, if you have questions as we go, we can bring those into the conversation as we go. Okay. So I have Dr. Kim McKenna here, and Kim, why don't you tell us just a little bit of background about where the idea for this came from and, what this is all about?
Well, the COA collects a tremendous amount of data every year. Mm-hmm. And so a few years we were talking about, wouldn't it be great to sort of link some of the data from what people are actually doing in clinical to what their outcomes might be? And so the team that did this actually, devised the study, looked at, okay, what were some of the skills that people were doing that were substituting simulation for some of the skills, and how did that correlate with the exam success?
Yeah.
And so that's kind of where it came from. And then they went through. I wasn't involved. I was involved in sort of the original idea, but then the other team went through and sort of decided, okay, which skills are we going to pull and include with this? And some of that was things that we knew historically people were having trouble getting anyway, but we also know that about 55% of programs are reporting difficulty in getting clinical placements. And so we're always sort of trying to figure out how much can you substitute and still be kind of safe, still really give the students the experience that they need.
Yeah.
And, there was some background in this. Dave Page really can talk about this back in the days when we were doing FISDAP research. they were looked at, the number of hours of clinical and the number of hours in field, and how did that correlate, and found that actually the number of ALS team leads was the most strongly correlated to the ability to answer critical thinking or clinical decision-making questions. Sadly, this paper doesn't distinguish between field or clinical, but it at least is a signal to us that yes, we understand people have to be able to substitute for some things that they're unable to get, but it's not the whole answer.
Yeah, and we're talking about substitution. So we know that people not just substitute, but augment. So you might still have simulation and you have a clinical in an area. So that's another practice that we see quite a bit. And trying to get at that kind of sweet spot, what really does produce the competent provider at the end. Now, you said something also that I think is really important before we move into the study itself, and that is, you said the COA collects a lot of data. National Registry collects a lot of data. So where does that data come from? It comes from all these program directors that are here. So in annual reports, we actually looked at studies before at ACCREDITCON that used resource data, that used the resource assessment data, and looked in detail at where were the struggle points for programs. And we've, kind of driven change in that direction. So this is really important. And this is from your annual report. At the end of an annual report, you'll notice if you're in the position of program director long enough, you'll notice there's questions at the end that vary every year. And that's because that is kind of the interest area of that year. So this year happened to be 2019. Let's look at the research objective then first. But 2019 was going to be the year that we're looking at our graduates from 2019.
Well, I have to say that I think one of the things that pushed the COA forward to partner with the registry to do some of this research was at one of the very first ACCREDITCONs, when program directors were saying, you're collecting all of this information. What are you doing with this information? And so the COA started to look really critically at, you're right, what could we do? And so they partnered with the National Registry research team. And I think I should also say that increasing the amount of research and making research and data-driven decisions is one of our strategic objectives going forward for the next 2 years as a COA.
Yep, and Dr. Suter this morning presented the strategic plan, and you could see one of the wings or the elements of our strategic plan as a board, Kim and I are both board members, that is to use evidence to drive the improvements in paramedic programs. So that's one of the really important things to come out of this. And this is one other piece of the puzzle. So this research objective then was to describe the prevalence of simulation substitution for clinical skills and its association with paramedic educational program success. So that was the actual objective. The data that were used were the 2019, again, I believe I have a slide on that. Data from your annual report. So you might remember this. This year we had a different one, but this is from the annual report from 2021, which we know that we are 2 years in arrears. We gather data from 2 years ago. Going forward, there's going to be a self-correction on that. Spoiler alert, but. So in 2021, you were collecting data on your completers, your graduates from 2019. So this study looked at graduates from 2019 from the COA annual reports that were coming from programs in 2021. So the annual report, for anyone who's not familiar with it, collects, basic program demographics, outcomes of students, the thresholds of completion, registry pass rates or licensing pass rates, and the job placement. But also there's questions at the end, and the questions usually have to do with the number of hours of your program, some details, again, demographics of your program. And then on this particular annual report, there were questions on the use of simulation and whether or not you use to substitute some of the clinical skills and substitute clinical time with simulation. So that was the methods. So the first thing they we always look at are kind of the descriptive statistics, right? What's the characteristics of paramedic programs for graduating students in 2019? And this is what was done here was to determine program pass rate. This was not arbitrary, by the way. Greg Margolis and others produced research years ago. Were you part of that?
No, I wasn't. That was in 2009.
Oh, wow.
They did a
I
research
remember this.
study that really informed my practice as a program director. And what they did was they brought in paramedic program directors from high performing paramedic programs, people that had very high success on the certification exam. And they came up with 12 attributes of highly successful programs and people that had great success. And so I think it's really worth digging into because all of those points are still relevant to today.
They
really
are.
Yeah.
So it was nice that this came back because they used or you used, because you were a co-author, you used the same metric of programs with pass rates of either greater than or equal to 75%, and that's the program itself has pass rates of greater than or equal to 75% or lower than 75% as the definitions of the high performing and low performing. I'm really glad they didn't use those terms because that always makes you feel kind of bad. But so they used the same definition though as that earlier study, which I thought was a really good idea.
Yeah.
So when we look at this, though, what we're looking at is the total students enrolled. So we're comparing both of these types of programs and by the total students enrolled, by the NASEMSO regions where you find them, and by the months to completion. All these factors, why these factors? Let's ask you that. Months to completion, total hours of instruction, and then a breakdown under that instruction of clinical, field, and capstone. So why these factors? Why do we look at this?
Well, we know that the certification exam pass rates vary widely by region. If you look in the northwest corner, you'll see a lot of programs that have 90% or higher first attempt pass rates. Whereas if you look in kind of more the southern area, where actually there are way more programs, the pass rates tend to be lower. So looking at it by region, could that be a factor? They also looked at it by program length, months to completion. That's really been associated with attrition before. So longer programs that are longer than 12 months tend to have more attrition than programs that are less than 12 months. And then the total hours of field experience and especially capstone, I think is important. Although that's always sort of a little hard to quantify because total hours of field experience really depends on what kind of a system that you're working in. You know, how many calls per day are you running? How many of them are ALS calls? All of those things, because we know that that's really, those ALS team leads are so strongly correlated with critical thinking. And then the hours of clinical experience are important because that's where you get to see, you tend to get more opportunity to do hands-on skills. You know, that's where learners are, learning how to start their IVs and they're actually seeing a real baby live birth, not something on film. That they really get to experience it through all of their senses when they get to see it. They're actually getting to probably intubate patients more in the clinical setting because we know in the field now, we're really downplaying, orotracheal intubation compared to what we used to, especially in cardiac arrest. A lot of people are going to supraglottic instead of, so we know that they're going to get exposure to things, even though it's different. And I think the big difference in clinical, in my mind, is that they are not the decision maker in the clinical setting. They're getting to see the patient. They're getting to see what does somebody who's really sick look like? What does a baby look like in those first moments after birth? What does it feel like when you put that laryngoscope blade into the mouth and that have to deal with the tongue for the first few times? But you're not the one that's making the decision. How do I need to manage this patient's airway? Is this baby a baby that's going to need resuscitation? So that's where the difference is in that ALS team lead between what they're doing in clinical. Because in clinical, they're just being told, go start an IV.
Yeah.
or intubate this patient who we've already paralyzed.
Yeah.
So,
And the way, to your point about the neonates too, or newborns, they get to see how they're handled too.
Yep.
Like that's one of the comments we hear from our labor and delivery
Mhm.
rotations is, wow, I can't believe how aggressively you can handle a newborn. Look at the nurses are doing this and the midwives. And so that's valuable. And so a lot of people will say that's a good, opportunity to supplement. But what if you can't see that? And what if you need to actually substitute? And so that's what we looked at here a bit. Another background piece that's mentioned in the article is the big study that was done in nursing by the NCSBN, which is a National State Council or Council of State Boards of Nursing, registered nursing. And that was a big study. That was a randomized controlled trial, very worthwhile looking up. Hayden, I think, is the primary author. Yeah, great article. And they looked all the way out to the workplace. They measured outcomes all the way out to the workplace in terms of competency and found that about up to 50% of their clinical hours or clinical experiences. I'm not sure if it went by experiences or hours, because nursing, varies in terms of their, state to state as well.
However,
yeah, 50% could be substituted with simulation.
But the however
okay.
there is that the simulation is pretty defined there.
Yes.
It's very high quality, very defined. They have expertise in simulation and
yeah, you have to read that study because that study, the faculty were trained. This was, highly controlled, so a controlled setting for their simulation. So very standardized, very trained, and so yeah, very very much.
And cost a lot of money
Yeah.
to do, which
Yes.
is why we'll probably never be able to do it in EMS,
Yeah.
honestly.
Yeah, it's a really important one though. And you also could see if the actual decay of where you don't get that effect, where it's okay, 75% is too much,
Right.
Where you could see it kind of fall off. So in this study, we could look at, retrospectively and from these demographics, we're seeing sort of similar to what Kim had said. The one thing about the Southern region though, is you do have a huge number of programs compared to other areas. So in the South, you can see that's where a lot of these programs are, period, whether they're, the high performing or low performing programs, according to the definition. Okay, the other factor was whether the presence of full-time faculty. How many of these, high performing versus low performing have full-time faculty? We're not seeing a whole huge difference here. I mean, maybe in the area of the 4+, who has 4+ full-time faculty? And again, this is about data that is, entered in an annual report. Did someone mix in their faculty from EMR and EMT? I think that the questions were pretty clear to delineate, but, it's still reported data. So we don't know, no one's going out to make sure that these numbers are correct. And then whether or not there's a certificate, associate's, or bachelor's degree. The other, let's see, what other aspects were in here? Then attrition. So attrition was another one, and that's a hot topic. We were just talking about this in a session this morning, retention and attrition. And the comparison here between the two programs was pretty much not much different, right? So between the two. So attrition, I don't know what to take from that, except to say that attrition's a problem.
It is. And I think, it's something that a program has some control over often.
Yeah.
And, you could theoretically change your certification rates if you caused a lot more attrition in your program. If you early on got rid of people you didn't think were going to make it and you didn't help them along or whatever. But thankfully, it doesn't look like this happening.
So I think overall in the demographics, what we were seeing then is over half of the programs reported first attempt certifying pass rate of equal to or greater than 75% of their program cohorts, and had a median of 18 students, and were primarily in the South Nesumseo region. So about half of them report that they have greater than one full-time faculty member, and the months up to completion was almost identical, about 12 months. And about a median of, about 1,200 hours, 1,175, which is what we usually say paramedic programs are around that. And then almost half of them reported an attrition rate of under 20%. But, I know a lot of people really struggle with that. Okay, so now we get into the simulation training details for programs graduating students in 2019. Again, organized by program pass rates. So, these are the characteristics of the simulation, whether it's a task trainer, a simple mannequin, an intermediate mannequin, an advanced mannequin, virtual reality. And this made me think of the super study that you were primary author of years ago. So one of the things, and if you're not familiar with the super study, that was a study that had to do with simulation use in programs, in paramedic programs, which found that a lot of people have the higher the advanced mannequin, the more likely it was to be found in a box and nobody knows how to use it.
Exactly. And I still hear stories about that all the time. So yeah, it's hard to say just because you have it, are you actually using it? That's kind of the sad truth. So
yeah, and another thing about this is there's some pretty good evidence coming out here and there, and one in particular that we looked at, I know about pediatric education, and I think it was a continuing education model, so not an initial education model, and the comparison of the different types of learning modalities, whether it was a lecture and skills, a low fidelity kind of simulation, task trainer kind of simulation, whether it was a high fidelity, longer, more involved simulation, and the outcomes. And it was the low fidelity, the low to moderate fidelity, the tabletop, here's your baby, you will run this cardiac arrest kind of thing that produced the better outcomes. So that's another thing I think is that we tend to think we need the $100,000 immersion rooms and the crying mannequins and everything, and not necessarily so. And some of the education is kind of pointing in multiple directions there.
I think there are ways to create fidelity without the really expensive mannequins, live patients I was just visiting one of the vendors, and they have like a pulse oximetry probe you can put on somebody's finger, and then just from your iPhone, you can control that blood glucose monitor,
about time for that
thermometer, so that it's not like they're just asking for the temperature or asking for this. They actually have to put the device on that they would be using, and then there are like so many environmental ways, just things like crying babies can create fidelity.
Yes.
Really can create somebody's heart rate to go up.
That's right. And Kim and I had an opportunity to work on the simulation recommendations that are on the COA EMSP resource library on the website. And there is, a lot of literature we looked at, we recently updated it. Dave Page worked on it with us. And so that's a great document to help with it. And one of the key points there is fidelity doesn't mean technology. Fidelity means reality. So how real can we make it for the student? And sometimes it is just adding sound or smell or a real person rather than a rubber mannequin.
Yeah.
Sometimes that can do it. I always say if they can make the mannequins change skin, that would be really helpful. Or
someday.
Simulated.
Someday. I'm excited
the virtual
to see
one too. So that's one thing.
VR.
Yeah.
It's interesting to me that I feel like we're right on the cusp with VR of, having some really exciting things to be able to happen, especially in programs that are doing hybrid and they can do some VR cases through distance ed. I know there was a multi-center study on that.
Yeah, that's right. That's right.
But
virtual reality.
But it hasn't taken off yet, and I think we're just almost there.
Yeah, there's cost factors and training factors that usually go with it, and I think that's one of the things we're all kind of looking at. But it's certainly not a reason to give it up, because there's definite advantages.
Right.
You can actually see changing. You can have multiple age groups. You don't have to buy multiple age group mannequins. Or you can have a mix of both. Somewhere the answer is the mix of everything, right? And sharing probably. Okay, so when we look at this, the types of task trainer, types of mannequins, and were there any differences? Most programs reported access to task trainers and simple, intermediate, advanced. About 10% had access to VR. That's bigger than I thought. I mean, that's actually a big number when you think about the number of programs here. And let's see, simulation was substituted. So then the next piece of it, and really no difference between the programs that were high performing or low performing in terms of what types of mannequins they had. So again,
Sure.
another comparison. Simulation substitution, however, this is where we start to see a little bit of a difference. So simulation substitution, it was substituted for 11 identified skills, and we'll look at those skills in a second. At a, let's see, median rate of 3 for the total population, but 59%. And again, this is out of 640 programs, right? We're reporting substitution of at least one clinical skill. Simulation was used in greater than 8 skills by 16% of education programs. So distribution for the first attempt pass rates are shown in one of the tables that you guys, we didn't project for you guys, but when we look at it, where we start to see the difference is when there are greater than 5 substituted skills. And that's where we see, more substitution tends to be in the group with the lower than 75% of their program passing first attempt pass rate. So that's actually where we start to see the difference. And then the types of substitutions. So pediatric intubation, IO insertion, electrical therapy, supraglottic airway, childbirth, that doesn't surprise me too much.
No, I don't think, does that
pediatric-
anybody out here? in
Yeah,
the
I was going to
audience?
say, yeah.
Uh-huh. Go ahead.
Does that, you go to L&D? Yeah, and you do a simulation follow-up. That's all. I think the two of those is a really good practice. So you can get into labor and delivery, and they can at least see what's going on. I think maybe sometimes we undervalue the observation part, and to that part of it is so valuable to see the real birth, the baby, the way that the baby is handled, and the way that the fundal massage. I mean, maybe you can get in there and get fundal massage.
Yeah, I think it's important to keep in mind again that this was 2019.
Yes.
And I don't think things are getting better. I see a lot of heads.
Yeah,
No, they're
yeah.
not getting better. In fact, what we're hearing is that things have stayed difficult since the pandemic, which is 5 years old, and some places are still using that as an excuse not to let our students come back in. And so, this problem is likely not any better now than it was back in 2019. And
Yeah.
in fact, could be
probably worse.
Yeah.
Because
yeah.
we did, and I think if it hasn't been shown in the general session, it will be shown somewhere along the line. We had some of that data, I think, in one of our sessions, that one of the big reasons still for the struggle for clinical sites is aftermath of the COVID-19 pandemic. So
Yeah.
Still to this day, and I have actually seen that on a site visit too. So it's still hanging out there. So I'm sure it's, like you said, a little bit worse for that. In the chat, by the way, those of you who are online, Dave Page, who is ill, and I really appreciate you participating, Dave. I know it's just driving you crazy not to be here. He is putting in the links to the articles we're mentioning. So the super study is in there, and the study by Greg Margolis earlier. Also, Aaron Donathan's study on the virtual reality, which has been mentioned a couple times here at ACCREDITCON. It was mentioned because there's a few people who participated in that study that compared virtual reality simulations and real. Yeah, yeah, that was just a really great one to look up as well. Those links are in the chat here. So if you want to pull those articles as well, those are great ones, a good background leading into this, and then where we're going to go from here. So looking at the skills here, not a surprise, and these are again in numerical order. So we went through the pediatrics and IO, supraglottic, childbirth, electrical therapy. Then, look at all the airway, adult intubation, endotracheal suctioning, in addition to the pediatric airway and supraglottic airway above that. So a lot of really critical airway stuff. And that might reflect also struggles with the OR, with getting into the OR. One of the sessions coming up this afternoon at 3, which I would not miss, is our 2 anesthesiologists who are on the board. One is the board chair, Dr. Michael Suter, and then our new board member, dynamic, was a paramedic, became an anesthesiologist, Dr. Chris Stevens. Is it Stevens? Yeah. He's going to be, they're going to be talking back and forth about airway management. Very good session coming up. So the others are patient assessment. That was a little surprise to me.
Yeah.
Patient assessment and IV access, that was surprising too. And again, we're seeing pretty big differences between the programs that have lower than 75% versus those that whose pass rates are greater than or equal to in terms of how much substituting they do in each of these areas. So, and medication administration, which is another thing you would really like to have in the real setting.
Yeah.
Guided by, nurse to go through all of the steps, the safety or preceptor, paramedic. Patient interaction, that was an interesting one too.
It is too. And I wonder if it's sort of the same problem we talked about in a session yesterday about sometimes students don't enter data correctly. So if they're in a clinical setting and they have a patient who, let's say, had a seizure and fell, and they also have an extremity injury when they fell from their seizure.
Yeah.
Are they entering that encounter as both a trauma encounter and as a medical encounter? And that just takes a lot of time by the clinical coordinator or program director, if you don't have one, in the very beginning to make sure that they get that right so that you don't end up having to replace things. But if they didn't see those things either, it's hard to substitute with simulation how somebody looks when they're in trouble. Just those little things, those little patterns that you learn how to recognize over time through various encounters. So
also teamwork, team dynamics, delegation, all of those kinds of things. I think simulation actually is a powerful tool for that.
Yeah.
Again, when trained, that's the other thing, the training in simulation. So the last thing, so now you have all of kind of the numbers, right? The raw data and the comparison of percentages. But what about, trying to figure out a model? They did a multivariate modeling to determine the odds of first-time certification exam success and the odds of reporting that you have simulation substitution. So tell us about this without just looking at p-values, hide the p-values.
So for multivariate logistic regression is you basically dump in all of those other factors and then your outcome that you're hoping for to sort of see, are there other things, given all the other factors, what is the actual effect of substituting up to 5 to 8, and so on and so forth. And so it takes into consideration all of the other pieces of the program and says, okay, we're going to exclude all that. And even when include all of that, and even with all that, here's what we're finding. I think I did a terrible job of explaining that.
No, but so essentially what we're seeing though is that those programs that have when we look at this, the odds of passing national registry first time or being in your program that passes
goes down if you have if you substitute greater than 5, and then greater than 8 also,
and again, it's an association, right? So we don't really know.
Significant. And the other piece that we don't really know is, okay, when you substitute it, so if you're substituting, let's say vascular access, are you substituting just this? Are they doing it on a live person? Probably not. Are they doing it on a mannequin where you're just like, okay, just go ahead and put I shouldn't step away from here. Just go ahead and stick a line in this mannequin, and then we're going to check you off. Or are they integrating the skills within the context of actual simulated scenario? Because there's a big difference between that isolated skill, the decision-making, the communication, the pressure that you might feel if you're trying to do two things at once, when you're moving above that kind of proficient level and you're trying to get up to articulation in your psychomotor skills, that means you're doing more than one thing while you're actually doing the skill. And so that simulation is really important. And then of course the stress in the real situation is even greater. And of course the whole tactile piece of starting an IV on a real person. It's like
Oh,
completely
entirely different. Yeah, entirely different. And we don't know numbers too. Some it was may have been sort of a yes, no, or how often, and you had ranges too to select. So it wasn't like people didn't start an IV completely, but they may have used more substitution than others. Dave says that Delaney has a question. Delaney, is someone unmuted? To ask the
I'm not
question.
sure if they can.
Yeah, I'm not sure if oh, there's Delaney. I see you now.
Oh.
I hope I'm saying that right. Is it Delaney?
Mhm.
Oh, ask to unmute. Yeah.
Hi.
Hi.
I didn't actually have a meeting, but sorry, a question, but I'm really grateful to be here and hear about this amazing research. So,
Oh, great. Thanks for joining us.
yeah, of course.
Oh, Dave putting you on the spot.
Oh my goodness.
I-
You know, in Zoom now, if you like just stretching and you wave your hand, then all of a sudden your hand goes up on Zoom and you're like, oh.
Or you accidentally hit the button. How about Dr. Bill Toon? We have not heard anything from you. I'm super surprised about that. Are you still out there?
So while Bill's unmuting,
Take some time to
basically what they found was that like you were almost 50% less likely to meet that goal of greater than 75% if you substituted more than 5 skills. So that's a pretty significant odds, more than 50% odds of not being able to pass on the first attempt if you substituted more than 5 or 8. Again, there's a lot of limitations to this.
Yes.
And so I think the thing that we should take from this is this is a signal. If we're going to substitute, then should we be making sure that we're substituting them in really authentic simulations, or is that even not enough? Question. Hang on.
I'm here.
Bill's here too. Go ahead, Bill.
So, first of all, I love all the work that we need to be doing in this area, and it needs to continue because, the reality is there's lots of people competing for those clinical spots and everything. And can we create a meaningful experience? I just started working in a medical school sim lab, and boy, it'd be nice to have money like they are able to dump into that kind of facility. But I'm still surprised that even there, they don't use the fidelity to the level that it could be used. And I'm very surprised about that.
Yeah.
So that is a challenge. And I think it would be better to have people have lower fidelity mannequins so they can do more training with their personnel on how to do simulation well.
Yeah.
Than to spend money on something that sits in a room or a box and doesn't get utilized. So that would be my message, is that the power will come from the quality of the simulation, and whether you're using standardized patients or a combination of task trainers and standardized patients and stuff, and create the situations where they need to get the experience. I think that's more powerful. And I really think that if you want to look at VR, I believe Rob Terrio just published a book talking about that. And I don't have the name right at the top of my head, but those of you who know him, he's devoted a lot of his time to the area of virtual reality.
Yeah.
And for the last several years and I think he's due to retire soon, but he did just come out with a book that would be worth everyone picking up and looking at, because he's really futuristic in looking at that direction.
Great. Thanks, Bill. We have a question in the audience here.
I'm just curious, you talk a lot about substitution. Can you just explain that a little bit? This is kind of what we use as substitution.
Yeah, so the question is what is meant by substitution? And that I would say too, that is a limitation of the study, because there was no real, as far as I remember, a definition in filling out the survey of that annual report many years ago, whether or not there was a definition of what does it mean by substituting. And because it wasn't asking how much simulation do you do in this area, it was asking you, do you have to substitute some of these, because essentially it was suggesting that it was hard to get, or it was better to augment with simulation. Those were the two suggestions I got from it. There is something in here that means you're instead of being, so that the real example, I think the common one is labor and delivery. The common one is we can't get into labor and delivery, or OR. That is, to me, an urgent need. We need to be able to get into the OR. If you can't get into the OR, you instead use mannequins. That is a substitution for a clinical, because we can't get into the clinical setting. The labor and delivery is the other one. We can't get into labor and delivery, so we just use simulation. So that means that we're considering that as a substitution for simulation. Dave,
I want to, before you leave that, I want you to talk about, I think one of the drawbacks, though, about airway management task trainers or even the high fidelity mannequins, they do not replicate the human airway.
not even close.
That's and they nor the
Wrestle with the tongue or open a mouth.
Yeah, open a mouth. But then even the mask seal, I watch people do mannequin mask seals, and their fingers get white from trying to hold the seal in there. And a human isn't like that. And so even if they don't do direct laryngoscopy, there's so much they can still learn in the operating room, even if they just get the opportunity to talk about ventilation and monitoring and the medications they use for the induction and stuff. And there's great power that can come from that if you can design that. And sometimes if you take a step back from direct laryngoscopy and look at the other aspects of it, there still could be a wonderful learning environment. And task trainers right now, I actually believe, encourage incorrect technique. That's my fear. And I would like to study it if I could do that and prove it. But through observation, I see a lot of bad technique. So
Dave has something in the chat that I think is really worthwhile in terms of the research. And that is substitution just a proxy, a surrogate marker for a program that just doesn't have a lot of resources? So in other words, is that really the common thing? So when you do retrospective research like this, we know that one of the limitations is we can only say this is associated with that. We can't say it's because of it. And it may be that we didn't look at other factors that do contribute that might also show up, like a lack of resources, lack of availability to certain things. So that's a really good point. And Adam Hoffman, thank you for liking that comment. I think it's a really important one when you're considering research outcomes and when you're thinking about next steps. So what would be, when you hear and you read this research and you see the retrospective data, now what would be a logical next step to at least decide what's the next step in the research? Because I think there's more research to be done here before you can say anything, about what people should do.
I honestly feel like there's opportunity for qualitative research in the area, like actually finding people that are in the group that was substituting and talking about what, why were you substituting? When you substituted, tell me how you did it. Was it just an isolated skill on a mannequin? Just put the tube in, that's all I want you to do. Or was it more really deliberate practice with decision-making embedded in there as well? So,
and to your point, what is their definition of substitution? What if they didn't have a clinical rotation to begin with? That's not even in their program. So it's not considered a substitution if you never had it to begin with, right? So what if that is the way we train? We train with task trainers, and that's it. That there's nothing to say that isn't part of it. So there's more to ask, right? More to ask.
Use the same instructors and stuff to do like a study of like, hey, this court, we're doing more simulation and where we don't. Yeah. The same factors. Trying to use other schools is also every school the same, but
so many variables.
Also, we've seen, here's the other thing. We don't just look at EMS research here. We look at anesthesia research, and we look at, I'm sorry, they can't hear online. So the idea here was to do cohort comparisons, have, some in one cohort doing one thing and some in another, same instructors, different skills, something.
Like what the nursing
Yeah,
people did,
exactly. Except they went
essentially.
like longitudinally with multiple centers,
Yeah.
which, Aaron did the study with the VR. So this kind of thing is pretty doable. It was, that was I mean, she's so relaxed. That was a rough study to run, but she did it. And that was great, you guys. And you were on that team. Yeah, that was a really good study. Congratulations. So we're at our hour, but I don't know if you have any final words to say about this and where we go from here. Qualitative research, you were saying?
Hey, we started late.
We had to start late. We're at a conference. We're not all, home in Arizona working out and enjoying ourselves.
Yeah, no, I just want to say that I think there's a great awareness of how difficult clinical access is right now. In fact, the executive committees of the COA and the registry, we met last night and talked about what, are there opportunities for us to try and get a group together to try and help. Will never solve the problem. It's been a problem since I started teaching in the EMS, and that's many moons ago. But are there opportunities for us to at least get together and try and identify some possible resources or solutions to the problem? So we understand it's a problem, and we're just trying to find out, through this research, like how often is it okay to substitute? We just need to learn more to try and help with this problem, because we recognize that it's a huge problem in the industry.
Again, I do want to say Adam Hoffman makes a great point in here, which is this does kind of go in the opposite direction of what the NCSBN found, which kind of, again, goes back to training. Yeah. How many of our folks know really how to run good, high quality simulations? So faculty preparation and training and resources into being an educator, I think that's an area we all talk about as an area of need. So great point. Thank you for making that.
Yeah, I'd be interested to know how many people are actually credentialed in simulation in EMS. I know Megan is. But, none of our educators were at the school that I was at. So that, that might be an opportunity.
Yep. And before we close out here, I do want to say, check out prehospitalcare.org. There are a few summits coming up in, I think, Austin, New York, and one other place that I'm looking up here in the chat that Dave mentioned. But we have a couple, just check out prehospitalcare.org. There's 3 summits coming up, ESO and others. And go ahead and toss your hat in the research ring. Remember, join us next month too, June 26th at 10 a.m. Pacific, noon Central. We will do the full hour just for Built-In. No, we always usually do the full hour, but we are at ACCREDITCON now. We had to start a little late because I have sessions back and forth, and so does Kim. So we're running room to room. But next month, we're going to be looking at something really interesting, which is preparing for death and dying and bereavement care, student paramedic perspectives on a novel learning module. So we're going to be looking at a learning module that was implemented, and what did the students think about it when they were having to prepare for death, dying, and bereavement, and talk to patients and families about that. So our next clinical journal club is Monday, June 8th. So don't forget about that. And remember, you can join us live each month. You can register at prehospitalcare.org. Don't forget to check out the YouTube channel, and you can subscribe. Oh, that's right. There is a new course from NAEMT on Breaking Bad News too. Well, let's talk about that next month when you join us. All right. Thank you everyone for joining us. Thank you guys in this room. Go ahead and have a great conference, and everyone else have a great day. We'll see you next time. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.